First of all, thanks for being here.
Oh yeah. I think most of you know me. For anybody who doesn't, my name is Brandy Koepp. I'm the pharmacy clinical coordinator here at MCR, and I am going to present today on ketamine, everybody's favorite new fun drug. I'm under the impression that EMS is getting a waiver, correct, to have ketamine in their rigs?
It's gotten, I think. They're just doing the rolling out the training right now.
Yeah.
We have, Pfizer has a waiver for IM ketamine for agitated delirium.
I do remember that, because I remember looking at that policy. So this is going to be just general overview of ketamine in itself. For anybody that actually attended the Trauma Grand Rounds presentation that I gave, that was a really long one. So that was about an hour. This is one that I've sort of toned down. It's a little more pertinent for EMS, pre-hospital, and then emergency type settings. So basically we're just going to go over the mechanism of action, the negative historical perceptions, and you'll see that a lot, especially if you're talking to some of the older ED providers. There's a lot of negativity when you're thinking about ketamine and talking about ketamine and why those exist. And then 2 areas of use besides anesthesia where they've been identified as an option for therapy. And of course I always have to throw the disclosures because you know I get paid for nothing. All right, we have our 43-year-old male, comes in, trauma, motorcycle accident, no past medical history. He's admitted through the ED and taken to surgery. Additionally to the unstable pelvic fractures, the patient has a colostomy, rectal tear, and embolization of the left internal iliac artery. After initial therapy and treatment, the patient requires wound care. During the sessions and after treatment with fentanyl and Versed, the patient becomes very delirious and difficult to control. In that case, when we're talking about an inpatient, what other options for therapy do we have in terms of pain control? And then if you flip that to a situation where you have somebody in an ED setting, if you give them fentanyl and Versed and they get delirious and a little wild, what are other options in those situations? Well, you can increase the dose of fentanyl and continue the Versed, increase the dose of midazolam and fentanyl. You can administer ketamine in place of midazolam and fentanyl, or administer ketamine and decrease the dose of fentanyl. So how about A? B? C? D? Yes. Okay. The answer is absolutely D, and the reason why we'll go into more depth, but if you're going to start giving ketamine in somebody who is also getting opioids, then you want to be very, very aware of how much opioid they're getting because of a potentiation. As we talk about ketamine, we'll start the historical journey because I'm a pharmacist and that's what we do. It was developed in '62 as a fast-acting general anesthetic, and then in the mid-'70s was approved by the FDA. It was used on the battlefield in Vietnam, and then started losing favor due to perceived side effects, and in 1999 was changed to a Schedule III by the DEA. And I want to really point out the fact that in the 70s, it was used on the battlefield. It was a great drug. So if you look at the history in terms of what you're looking with sedatives and pain control medication, even during the Civil War, they had things like morphine, but morphine is not really an optimal drug if you're talking about wartime, managing patients, evacuating them. So ketamine was actually a really great option because patients were able to actually be functional as they were evacuating off the field. Its primary mechanism is NMDA receptor antagonist. So NMDA receptors, glutamate, predominantly works on that, fundamental to excitatory neurotransmission, and it's critical for normal CNS function. So your NMDA receptors are firing all the time. Excess glutamate is bad. It basically can hit those receptor sites and cause excessive excitation and then cell apoptosis. So you can damage your neuronal cells because you have too much NMDA action. Thus, the neuroprotective role, as you're talking about ketamine, and we'll go more into it. So in patients that have cerebral ischemia, stroke, or brain trauma, and then also there are certain neurodegenerative disorders, what happens is there's a mass excess of glutamate, and what happens is that glutamate starts hitting those NMDA receptor sites, and then they're overstimulated, and then you get neuronal cell death. So ketamine actually, from that mechanism standpoint, can actually cause neuronal protection as opposed to neuronal damage, which is what one of the negative perceptions of ketamine has always been. And because, again, I like pictures, basically right here is, so basically right here you have your NMDA receptor site. You see up above you've got your glutamate attachment sites, and then your NMDA recognition site. And ketamine actually works right here, and it blocks that channel up. So you don't get that activation by the glutamate into the cell that you would normally have, because ketamine sits right there. There's a couple of components of ketamine that make it even better. One of it's probably kind of more technical, but it's called a slow trapper. So what happens is it sits in the site, and unlike a lot of other medications that they hit those receptor sites and then they pop right off, so they just go on and off. This guy kind of goes in, sits on that receptor site, has some coffee, maybe a donut, and then it pops off. And so you have a longer action of that blockage than you get with other NMDA receptor blockers. So Parkinson's drugs are one of those examples. They go on, they come off, and then you don't get that sitting action that you seem to see with ketamine. Other mechanisms of action, and this sort of alluded to in our patient case, opioid receptors, so mu and kappa. Actually, what they found is that there's more actual kappa action than mu action. So what are some drugs that work on the mu receptor sites? Fentanyl, morphine, hydromorphone. Those guys hang out on the mu receptor sites, so you get a little bit more dissociation. Kappa is actually good pain control, but maybe less of that euphoria that you kind of see on the mu receptor sites. So that's one of the reasons why ketamine is a great pain control med, but not necessarily the pain control med that you see that's similar to morphine and fentanyl and those kind of drugs where you get almost like a euphoria. You don't necessarily get that. The side effects from ketamine are predominantly caused from the NMDA site and the PCP type reaction where you get potentially hallucinations. It does have antagonistic interaction with monomergic muscarinic and nicotinic receptors, and if you can say that fast 5 times, I'll give you $10. So it does produce anticholinergic symptoms, sympathomimetic action, bronchodilation. This drug can actually, there's data now to support using it in status asthmaticus. So utilizing ketamine in patients that are refractory to other therapies for status asthmaticus, because it has that really nice dilation of the bronchioles. It also can create a lot of secretions. So if you give somebody ketamine and you start seeing a lot of secretions, that's a normal side effect. They have found that it can be a little bit reversed with anticholinesterases like physostigmine. The data is questionable on that. Really, ketamine's got a short enough half-life that it can go away. So not really something that you necessarily would need to reverse anyway. And why would you want to? And then high doses have been shown to have local anesthetic properties. So there are some situations where anesthesia will give intrathecally or in those sort of nerve block areas, but that really hasn't borne itself out.
Hey Brandy, back in the day we used to have like glycopyrrolate or atropine available to us if we were going to give ketamine IM just because of the
secretions.
Yeah.
Mm-hmm.
Is it something that we should worry about, or just suction, or just not even worry about it, or?
I think in those cases, suctioning is usually fine. Okay. You can get the secretions out that you need to. If it's getting to the point where they're a risk, an aspiration risk, you can always do a glycopyrrolate dose. Unfortunately, for a secretion, glycopyrrolate takes a little while to really kick in.
We have atropine available, so just a small dose, do you think? Like
you can do that. You can do a little sublingual atropine, actually. Oh, and yeah, that'll dry them out. Isn't that weird?
Atropine,
yeah, so it's actually something we even use in our comfort care patients whenever we're doing compassionate extubations and things like that. Drop a couple of the ophthalmic atropine drops under their tongue, and it dries up their mouth, so they don't get as many of those secretions. So that's also an option. You might want to start with 1 drop. Cotton mouth. But that's also an option if you're talking about a patient that has ketamine that you want to take care of the secretions. So,
Do you see that
possibility.
effect with IV too, I'm assuming, the salivation?
Yeah, it's there, but usually it's not as, I think with ketamine, it's hit or miss. It's sort of what you get with any single patient. You don't know that they're going to have that problem until they start having it. And so having the other options for therapy there are perfectly acceptable. I like the atropine idea only because the glycopyrrolate does take a little while to take effect. And also if you slap a scopolamine patch on them, then you also have to wait for that effect to happen. So atropine's sort of your fast acting, easy, and it's in an eyedropper, so you can just drop it. And by that time they're calm, right? Hopefully. And as I talked about earlier on the receptor sites, it's not just the NMDA receptors when we're talking about ketamine. Ketamine has a host of different receptor sites that it potentially works on, and not just the receptor site in general, but the downstream effects of the implications of where it sat. So you've got your NMDA sites, which is your hypnosis, but then it has some increase in dopamine. You've got some increase in decrease in your neurosteroids, and then all of those add up over time to actually really push the ketamine therapies in different directions. So you start with hypnosis, pain control, and then you move on to the psychomimesis, and then you actually can get antidepressive type side effects. So one of the really interesting things that I don't really go into here very much is that ketamine is now being used in a lot of facilities for its antidepressive effects. So they do a 0.5 milligram per kilo dose over 40 minutes. And it's like we talked about earlier, it's like a reset button. And these patients that are refractory to all their other antidepressants will walk out of that and not need any other antidepressants and be totally fine for however many months, and then they just have to come in and get another infusion whenever they start feeling bad again. So it's there, it has a lot of potential. It's just one of those drugs that has some negative connotations. And why the negative connotations? Well, there's the neurological illness and elevation of ICP. And I will tell you, and I think let me just double check. Yeah, I was gonna say, I think I had the studies on these, so I just wanted to make sure I had them. PTSD, and why would we be concerned about PTSD? Well, there's always that potential because of the hallucinogenic properties that you might make a PTSD patient worse. Emergence reactions, which we know is far more common in children than adults, and then abuse. Well, the neurologic illness and ICP elevations is actually a really interesting negative connotation that's been potentiated over the years when we're talking to different physician groups, neurosurgeons, trauma surgeons, and really all of that data is based on studies from the 1970s. And one of the things I like to point out is in medicine, how many of us are still doing the same kind of medical practice that was happening in the 1970s? Are you?
Absolutely.
Exactly. So, yes, I was not alive in the 70s either, but I would hope that medicine... But I would hope that as we're looking at medical practice through the years, that the way that we practice medicine in the 1970s has come a long way to 2016. And so when we're looking at these studies of reasons why there were ICP elevations and reasons why people had neurological illnesses, if you start looking and really delving into the literature, a lot of it is they were inducing analgesia and then they were using nitric oxide, which we all know in trauma patients is bad because it causes significant vasodilation of the intracranial vasculature, and then you can get an increase in ICPs. And so when you use that combination, of course they had elevations in ICPs because you were giving them nitric oxide on top of the ketamine. And the other component of ketamine is that it is very good for maintaining circulation. And so if you're vasodilating your intravascular vasculature, and then giving ketamine, which is increasing your cerebral perfusion pressures, well, of course you're going to get elevations in your ICP. So some of these studies that all of this information was based on was probably a little bit faulty in blaming the ketamine because it was other components of the therapies that actually caused the issues. They're actually now finding more benefits, as I talked about earlier, for neuroprotective, anti-epileptic, and preserved hemodynamics. So that's why we're having this conversation now. Because when we're looking at neurocritical care data, all of that old data is really old data. And the new data that's coming out is actually quite supportive as we're looking at ketamine. We talked about the ICP elevation. And then the other part that I didn't mention is that tumors, hydrocephalus, aseptic meningitis, and subarachnoid hemorrhage were the patient populations that actually they tested ketamine in these situations. So not only are we giving potentially other medications that cause vasodilation, we're also doing this in patients that already have a high risk of having those elevated ICPs. So again, you can't jump and blame ketamine for causing these issues when these patients were at a higher risk of having those problems anyway. Is there still concern for ICP? Absolutely. There always is concern for ICP. There's a lot of data in non-intubated, non-sedated patients that have neuropathology. And part of that is to just be very cautious of them and really assess the patient. But I think that in the critical care data, as you're looking at patients who are intubated and who actually have ICP monitors in, you're not seeing those ICP elevations when you're administering ketamine. So it's something to be cautious about just because the drug information says to be careful about it, but also in the grand scheme of things, there's probably a very low potential to cause detrimental outcomes because you're giving ketamine in those patients. And I like to say there is, when I'm thinking about it, if I have a patient that comes in and they are wild, head trauma, thrashing about, really, really hard to control, how much damage are they doing to themselves by being difficult to control and having high blood pressure because they're full of anxiety and they're just not controllable? Or by giving them ketamine and running the risk of elevating their ICP, but getting them to a manageable level, normalizing their blood pressure, and maintaining them in a calm state. And I would say that your second option is probably your better option, especially when we're talking about all the other medications you would potentially have to give to calm that patient down to the point of being able to control them.
Plus putting restraints on them, that is not good.
Exactly.
Somebody sit there in isometric muscle contraction against restraints.
Exactly.
Do you see it as a realistic alternative to RSI? Because for most of those patients, you don't know what's going on with them. You just know they're broken, and you do have to RSI them to put them down so you can paralyze them and get the CT scan. So I like the idea of this.
Mm-hmm.
However, can you still get a CAT scan in an efficient manner with ketamine only?
Yep. I've read multiple case reports. I was telling Tim about it, and case studies about ketamine utilization in the ED type areas. And one of the overall responses that you read is that when you have somebody who's violent and aggressive and agitated and you give them a big whopping dose of ketamine, they turn into a kitten and they do anything you want them to do. They're very directable, they're very manageable. They might be completely out of it, they may have hallucinations, but they will go through the CT scanner and you may not have to be as gnarly with them as you might have had to be otherwise. And I think that's where I think a lot of this niche for ketamine is, especially in an ED type environment, is that you're really able to more effectively manage those patients without having to intubate them.
Did the exact thing, that exact case the other day. The patient just couldn't stay still because of pain. No matter how much narcotic we gave. We gave 0.5 per kilo and she was able to just lie there for the CAT scan.
Mm-hmm. Yeah, it's, and for lack of a better phraseology, it's got exquisite pain control. So they've done studies, and I think I'll touch on this a little bit more, but they've done studies and looked at pain control in comparison to morphine, and it's as good or better than giving them equal doses of morphine. So the pain control when you're is actually
very,
with
very
ketamine.
good.
And then the other part about ICP elevation is when you're looking at undifferentiated critical care patients undergoing RSI, there was a study done by Jabra and colleagues that said that patients had no differences in outcomes when compared to ketamine versus etomidate for RSI. So, and in fact, I would argue that in patients that are undifferentiated, hypotensive, and hemodynamically unstable, ketamine is actually probably a better option than etomidate because you actually do maintain their perfusion pressures. Non-differentiated patients in RSI, so this is just more on the Jabra study that I put in, and I pretty much went over it. So you can give ketamine, you can give etomidate, there's no differences in those patients, but again, I would usually err on the side of ketamine just to maintain their perfusion pressures. And then important on that study, trauma patients did account for 104 of the patients in the study. So this is not a study that was excluding those patients that were trauma patients that could have had some sort of a neuro issue secondary to head trauma. So this is all patients. The doses were 0.3 versus 2 milligrams per kilo on the ketamine. So if you're ever looking for a dose of ketamine, 2 milligrams per kilo is pretty straightforward. It's an easy calculation. For IM, we say 4, so you can give a bigger dose. I will tell you that in the ICUs, I have given 4 milligrams per kilo IV to a patient, and he was still awake. So if you have patients that have significant drug use history, alcohol use history, they may require higher doses, and they still may be able to talk to you through that. Just a word to the wise. And then we went over that study. So then we go to the post-traumatic stress disorder component of the discussion. And so as we're talking about side effects of ketamine, what are some of the side effects? Well, hallucinations. We all know that ketamine is a PCP derivative, and so there are definitely potentials there to have hallucinations in those patients. So one of the reasons why in PTSD patients the VA very early on said don't do it is because they were very concerned about the hallucinations being negative in terms of creating additional PTSD episodes in patients from Vietnam. And that's when that started to take hold. There's more and more accumulating evidence that is actually supporting ketamine in these patients. It's not a contraindication to give patients that have PTSD ketamine. And they've actually like I said earlier, started using it more for refractory depression. And so some of these PTSD patients that have really horrible depression have actually been benefiting from ketamine infusions. So really not as detrimental to PTSD patients as everybody would think. They did do a study looking at PTSD patients compared to, sorry, I haven't looked at this study in a while. But they basically figured that ketamine would be associated with significantly greater reduction in core PTSD symptom levels in 24 hours after a single IV infusion. And the reason they did this is because there's so much negative connotations in PTSD with ketamine. They wanted to have some sort of concept study to prove that these patients actually could benefit from ketamine. And so they did. And then they also had the hypothesis that it would have rapid antidepressant effects. And as you can see, there are definitely some exclusion criteria. So alcohol abuse, we know a lot of PTSD patients do have alcohol abuse issues, so maybe a lot of those would have been pulled out in that. And active suicidal or homicidal ideation, so that would be actively, excessively depressed. So maybe the patients may not have been as depressed as they initially thought. But what they did find is that those patients had more improvement with ketamine than they did with Versed. And in addition to the symptoms, 7 patients assigned to the ketamine group first had significantly reduced infusions compared to only 1 midazolam patient. And so when you're looking at that data, you're seeing that ketamine actually does have some positive impacts on your PTSD patients, especially when it comes to depression. They did report out dissociative symptoms, but they peaked after 40 minutes and resolved by 120. So the hallucinations and dissociations are actually pretty short-lived. The ones that did last a little bit longer were going to be the blurred vision, the dry mouth, which is weird to me because that's actually, they should have a lot of secretions. So it makes me wonder what else they were doing to them. The restlessness and the fatigue. But I think in the grand scheme of things, those are pretty acceptable side effects when you're looking at somebody who is sick or violent or just needs some sort of a sedation or pain control medication. And then the single dose of ketamine compared to midazolam resulted in less PTSD symptoms, and then it was actually maintained a lot better. So probably not a bad idea in PTSD patients. They also looked at PTSD in soldiers with significant burns, comparing morphine and ketamine to morphine only. These patients actually had much better outcomes if they got the ketamine and morphine. They required less morphine. And interestingly enough, the patients that got ketamine and morphine had less PTSD symptoms after they were appropriately treated and after the fact. And so one of the theoretical reasons for that is that patients that had less pain when they were in therapy had less PTSD post-therapy. So better pain control, less PTSD, which is another reason why you would not be particularly concerned in PTSD patients. Emergence reactions, one of the most likely reactions, see them way, way more in pediatric patients. So our adult patients don't tend to have emergence reactions like our peds patients. So in our pediatric population, if you're giving ketamine, it's something to be very, very aware of. I think our anesthesia colleagues all know that they usually are expecting it, and sometimes we'll just give a little benzodiazepine to sort of take the edge off for the little kiddos. But most adult patients don't necessarily have these emergence reactions. Some of the most common side effects were, of course, dreams, but I wanted to point out the numbers of that. So when they did a meta-analysis and looked at the types of dreams people were having, only about 2.4%, so 10 of the 421 patients they looked at had really bad dreams, successive nightmares, not really good. But 18%, so 29 of 159 that they looked at actually had pleasant dreams. And one of the components that a lot of practitioners that use ketamine a lot say is if you prepare your patients for what they might experience, they can manage their own dreams. So if you proactively in these patients that you're going to give it to say, hey, I'm going to give you this medication, you may have some dreams, but you can make the dreams whatever you want. A lot of times patients can manage their own dreams and actually have positive experiences associated with the medication. So yeah, I mean, it's one of the only drugs I've ever heard of that you can actively coach somebody into having a really great experience.
I have no idea why we're going through so much ketamine.
Who knows?
It's just out of date a lot.
Right? So, and this is one of the reasons why I've become such a big proponent of it, because I think that there's so many great benefits of it and so many ways that you can direct patients to have better experiences with it than just like slamming them full of fentanyl and Versed. So you can give the benzodiazepines, which I said earlier, in order to sort of circumvent any sort of emergence reactions. There's different ways to do it. You can do the pre-dissociation, the pre-emergence, or the PRN. Honestly, when I think about strategies to relieve distress, I feel like the coaching, especially if they're coachable at that point and they're able to listen, is probably the best way to do it. And then to use a PRN, so just an as-needed benzo, if you need to give them just a little bit to take an edge off if they happen to start having a bad dream. Pre-dissociation and pre-emergence are more challenging for me to support because we see such a high incidence of delirium in this hospital and in our patients coming into the hospital. And one of the reasons that we know that benzos are bad is because they can cause delirium. So I'm not a huge fan of just proactively giving people benzos, although I'm kind of a big fan of proactively giving them ketamine. So take it for what you will on that one. And then abuse, and this one's my favorite one because I like to say the word K-hole. But so abuse is actually quite common with ketamine in other countries. In the United States, not as much, probably because it's a Schedule III through the DEA, so it's a little bit harder for people to get their hands on. Some of the names that you'll probably hear it called, especially if you're out on the street: Special K, Vitamin K, Lady K, K pills. And when you hear somebody say, I'm in the K-hole, that means that they're high on ketamine, because that's kind of the consistent theme of, oh, I'm high on ketamine, I'm in a K-hole. And it has probably something to do with the dissociation that happens around it. It's also known as a pharmacologist's nightmare because of the complex mechanisms that we deal with when we're talking about ketamine. So we went through all of those earlier. And as you have a patient coming in who's an abuser of ketamine, there's a lot of components to that people have a hard time pointing out. Well, it's ketamine, well, it's PCP, well, it's LSD, well, opioids. So it's really hard to make that differentiation without knowing exactly what they're taking. And the other problem is that if you test them with a tox screen, you're going to have a PCP come out instead of ketamine. So you don't know for certain if they're PCP or if they're a ketamine user. The beauty is that it can be administered IV, IM, nasally, subcutaneously, PO, rectally, and intrathecally. So this drug is very versatile. You can use it anywhere, you can use it anyhow you want. And so people who abuse medications, we know whatever's easiest, whatever comes at the time, and if you have that diversity and availability, you can do whatever you want with it. And then just the drug trance, out-of-body experience. They have no painful sensations because of those kappa blocking opioid activity. And so it's kind of a great drug to abuse, right? Interestingly enough, how does it compare to other drugs? Well, I'd like to point out that we use 26 to 36 million people with opioid abuse issues in the United States. We know it's a huge issue. We know a ton of patients that have opioid issues. In 2012, 2.1 million people suffer from prescription opioid abuse, and 467,000 people are addicted to heroin. How many of you guys have seen a heroin overdose around here? Yeah. Unfortunately, around here, it's pretty common. Well, the prevalence of ketamine abuse worldwide is unknown, but studies suggest a lifetime incidence of about 0.1% in the US and 4% in the UK. So when you're looking at a 0.1% in the US, that is unbelievably low in comparison to what we battle with opioids and methamphetamines and other abused medications. So it's something to keep in mind when people have that negative, well, it's a highly abused drug, everybody abuses it, and that's not true. Opioids are a way more abused drug, and we use opioids all the time in mass quantities. So something to be aware of. And then additional effects and beyond. The hallucinations we know. The other part is the sympathetic response, so increased heart rate, increased blood pressure, very common. And then risk versus benefit in patients with cardiac ischemia. So if you've got a patient who is actively having an MI and they're hard to control, ketamine may not be the best option for them. But again, what I said earlier, when you're looking at patients who are being challenging and hard to control and driving up their own blood pressures versus getting them calm and relaxed, what's the risk versus benefit on that? So it's used with caution, but not necessarily you can't use it all.
How transient are those effects?
They're usually pretty transient. I would have to look at numbers, but I would say you start seeing blood pressures go down within 10 to 20 minutes. So it's not, when you give it to them, you're not going to jack them up for a long period of time. It's just the transient. It goes up, you maintain a while, and then it goes down and plateaus out.
We use a lot of ketamine in New Mexico, and just a tiny bit of Versed will take that away. It really helps a lot, and it's quite remarkable how quickly it goes. And it doesn't take much of them.
Yeah, so there, and like you said, there's other options too to take care of your high blood pressure and heart rate issues as well. And then maintenance of your systemic vascular resistance, and then none or minimal respiratory depression. And I've heard plenty of people say, well, they gave them too much ketamine and we had to intubate them. No, that's not true. Actually, ketamine doesn't have any respiratory effects. It does have vasodilation in those respiratory areas. But the problem is the potentiation that you get if you've given them opioids, if they're already on opioids, or if you've given them a large quantity of benzodiazepines and then you give them ketamine, because that doesn't necessarily, there's no actual GABA, there might be a minimal amount of GABA activity from ketamine, but really you're just potentiating their relaxation, and then the benzos are causing your depression. So ketamine is not a respiratory depressant, but all the other stuff that you give to maintain these people is. It is on the rise. I know you guys, that's why I'm here today. So pre-hospital and in-hospital control of violent aggressive patients. We're actually working on an active protocol right now. It's already been signed off by trauma for inpatient control of violent aggressive patients. Basically, they buy themselves a dose of Ativan, they buy themselves a dose of Haldol, and then if they're still wild and woolly, they get a big dose of ketamine. And I'm ready to get that order set done and written and available. So it will be available not only in our ICUs, but it should be available also in our EDs. And that will be another option for therapy on a lot of those patients that we have a hard time controlling. Sedation in patients who are hemodynamically unstable. We've used this also in our ICUs. Pain control, it has very, very good pain control actions because of that opioid receptor site and also the potentiation of other opioids. Refractory status epilepticus, this one is kind of interesting. It's still a little bit on the newer side. There's definitely data that's been out a couple of years, but what they've started to find is in patients that are refractory to any other anti-epileptics that are in status, instead of putting them down with a barbiturate, they can actually give them big doses of ketamine and maybe smaller doses of barbs or of benzos, and they actually will come out of their status without any other help. So it's sort of what we talked about, the excessive glutamate activation of those neurons is bad, and when you block that, that may be what's causing that benefit for status. Benzodiazepine resistant alcohol withdrawal. We have actually used ketamine now for a couple of patients, and you guys have probably seen them when you give them so much benzo and you don't know how they're even still alive and they're still thrashing and angry. Well, ketamine has actually been shown to have potential impacts on that, not necessarily by taking away the benzos, because you still need to hit the GABA receptor sites, which are downregulated, but when you downregulate so many of those GABA sites, you actually upregulate the NMDA sites, so that's how you get functioning alcoholics, because NMDAs are excitatory. And so by blocking that NMDA receptor site, you actually can facilitate them being more functional as they're withdrawing from the alcohol. Mm-hmm.
Might be a little far off, but in comparison to Precedex, is Precedex an MDMA, or is that completely different? Am I just thinking of something else?
Precedex is alpha, central alpha acting.
Okay.
Precedex is not my favorite drug.
Oh, okay.
Which is why I'm getting the look right now.
Yeah, I'm just getting kind of look.
Well, just what you're talking about, children's users dexmedetomidine in children who have status asthmaticus and are needing some BiPAP, and they're young and they don't like the mask on, and I think that's their go-to drug because of the secretions.
For dexmedetomidine?
Yeah, but I mean, it's children's choice in those hypercapnic respiratory failure asthmatic patients who are young. But there's no reason you couldn't use this drug.
Yeah, that's what I mean. It's like, I mean, we use it on our little buddies with BiPAP when they don't tolerate it. But
I think
they were playing with that, because that was my question even before I got this slide was, I mean, how's it with DTs and stuff like that, which sounds like.
Yeah. So for kiddos, when you're talking about status asthmaticus, yeah, ketamine actually would be great The only problem is the emergence reactions that you see more with kids, so that might be some sort of limitation in those instances. The thing with dexmedetomidine that I always really harp on, because I feel like a lot of people have a misconstrued sense of benefit from it, is that it is central acting, so it's got a similar mechanism as clonidine, and except that it passes more in past that blood-brain barrier and gets into your central acting alpha in your brain, and that's where you get the anxiolysis and the calmness that you see with Precedex. But part of the problem with Precedex is it blocks vital signs because it causes bradycardia, it causes hypotension, and so in a patient that you're relying on vitals for to help drive, so especially alcohol withdrawal patients, you need their vitals to tell you if they're close to withdrawing or if they're moving in that direction. It blocks those. And so there have been actual studies that have shown patients that are on Precedex have actually had a higher risk of going through actual DTs and seizing than patients that are on just benzos alone. And part of that is because there's no prompt for patients to get additional benzo if they need it, because we're blocking those functions with dexmedetomidine. It's a very niche-y drug to me. It's great in an ICU setting for removal of a tube if you can't get it out. But other than that, I am not a super big fan of dexmedetomidine.
So we had used it back home. We had a high Native American population. We had like cut our intubations from withdrawals and DTs like in half. And the EDs, I was wondering, ketamine would, obviously, we could use ketamine to save intubations from terrible withdrawals in the long term. I feel like if you're giving just ketamine acutely, are you going to keep them to where you can keep them stable so you don't have to intubate?
And we've actually used ketamine. In fact, I had a patient that we used it in a couple of months ago now, and he required large quantities of benzos. I think he was all the way up to 16 milligrams an hour of Versed, and I had him up to 160 milligrams an hour of ketamine, and he required no intubation. And we had him in and out of the ICU within 7 days. And that was after he had acute methanol toxicity secondary to drinking antifreeze. No, propylene glycol, sorry. Whatever it was bad.
So in our protocols, one of the indications for using is that a patient for using ketamine is that respiratory failure patient who, we're getting set up, but you put 100% under the breather on, and they're trying to get, they're combative and they're all over the place. We can't get a pre-oxygenated, maybe we'll use BiPAP in that patient. So kind of while we're getting things all set up, we'll ketamine to kind of settle them down, kind of take away that agitated, pull things off. Yeah, it works very nice.
Yeah, should we say a little? So what's our dose in that situation?
I'd probably give like 0.5 or something, and then you can go ahead and use it as your sedative for RSI. And give them another, our dose is 1.5 there, but just give them a little, just to kind of, so you can at least get them pre-oxygenated. You're not having to hold them down. You can get all your, you can get ready for your intubation, get everything all set up. So.
And I would also like to point out that it's very, very, very hard to overdose on ketamine. So in patients, if you accidentally give them a 100-fold overdose, the ramifications of that are nominal. They're going to be high.
Yeah.
But they're not. But the ramifications of giving them an extra large dose are pretty low. And like I said the other day, I actually did recommend a 400 milligram bolus dose on a patient, and he was talking to me through it. So it's not one of those drugs that I'm particularly ever concerned with excessively overdosing, but you can underdose, certainly. And then just a little bit on the anger management issues component. We talked about that a little bit. The onset of action when we're talking about violent aggressive patients is less than 5 minutes. So when we're talking about patients who are wild and woolly and violent, then ketamine actually is a really great option, especially when you compare it to the onset of action of Haldol, Droperidol, and even the benzos, which are quick, but sometimes you don't give them enough.
Is that for IM or IV?
This is IV. Yeah. So.
It has a more predictable dose response than Haldol and Bedazzole.
Is the ED group had this, like does the ED group had this presentation, or is that?
I don't think you haven't specifically talked. I know a lot of us, it's becoming more mainstream in our practice.
I did do the trauma grand rounds talk, and I think most of the slide deck was disseminated throughout palliative, ED, trauma, and I believe the pulmonology intensivist group. So I think everybody is sort of aware of the information. They just are still getting comfortable putting it into practice. The other component of that is you've always had anesthesia who's been very close with ketamine and very tight about utilization. And so now it's also been motivating anesthesia to be a little bit more lenient in terms of their moderate sedation policies and who gets to use ketamine and how it gets to be used. And so they're also on their own learning curve in terms of kind of releasing some of the reins of the ketamine control. So that's another part of that. And then, just in case you're interested in any pre-hospital information, there's actually 2 different articles that I had that I put into this from Schlepke and Burnett that they were retrospective looking at pre-hospital ketamine for severely agitated and violent patients. And in these, 51 and 52 patients were identified in each study, and their doses ranged from 2.25 to 9.42 milligrams per kilo. Patients who required intubation typically had higher ketamine doses and had already received multiple benzodiazepines. So kind of what I said earlier.
Is this the one out of Columbus, Ohio, EMS, City of Columbus?
I think one of them is, and one of them is from Miami-Dade.
Okay.
Mm-hmm. And then Hopper et al. Have ketamine agitation and in the ED. It's a historical cohort study. They did 27 patients. They looked at changing in vital signs post-administration and the need for additional calming medication. And then I just put out how many patients were agitated prior to ketamine, 66%, and then 10 of the 18 that received ketamine needed no additional calming. So pretty decent numbers when you're talking about ED patients who are ultra agitated and over the course of their whole visit. And then additional calming medications were required in about 74% of the patients after ketamine. And then most of those patients, a lot of them were actually already intoxicated when they gave them ketamine, so that's one of the reasons why they needed more calming medications. And when you're going through withdrawal, right, we know that if you're going through an alcohol withdrawal or alcohol type situation, you probably do need benzos anyway. So ketamine is just kind of the adjunctive in that situation. And then they looked at the vital signs in all those patients and there are no significant changes. So if you are seeing increased heart rate, increased blood pressure, that's not the super common side effect. So like Gary said, we can just give a little benzo. And then it can be used in severely agitated patients, and it's a potential alternative for patients that are non-responsive to other therapies. So we talked about patient case follow-up. I actually said D. Apparently I put C. Go figure. So the patient was started on 25 to 100 milligrams of ketamine prior to each dressing change, tolerated wound care, no further interventions were required to keep the patient comfortable during the process, and no adverse effects were reported during the procedures. And this was actually a patient case. So we've actually started using it quite a bit for wound care and dressing changes in our ICUs as well. And then I always put my Superfly dose reference card at the back because I always find that very helpful. I couldn't find any reference that has all of this information in one table, so I put a table together for all of us. And we've actually used quite a few of these actually.
Hey, when you mix that up into a drip, how do you do it? What's your standard concentration?
Our standard,
1 vial plus 1 bag.
in Dwayne's
That
it.
works too.
Our standard concentration here is a 1-for-1, so we do 250 and a 250, just for a 1-to-1 continuous infusion. We do have a concentration for status epilepticus, and I've used it for the benzo-resistant withdrawal patients. That's a 5 per 1.
You know, the question that we only carry one 500 milligram.
Mhm.
Right.
Yeah,
Have we needed more than 500 milligrams at a point in time?
you shouldn't.
If you're mixing up a drip.
But,
I mean, if you're
some of
mixing up an
those
infusion.
people that could kind of fall out of that, I mean, I guess you can give them 400 IM as the maximum dose, and you got another 100 milligrams that you can get.
Mhm.
If they pull out their IV, you get another IV going and keep them down with that. But-
What are your thoughts on using it as, like, instead of using propofol, or instead of using Ativan, or excuse me, a fentanyl Versed drip, using a ketamine drip for sedation?
I think you can do it. I think that it's actually, we don't do it enough that people would be comfortable using it as a first line, but it's absolutely, as we get more and more comfortable with it, it could replace some of those combinations. So fentanyl Versed as the go-to sedation pain drip, because it does have very good sedative and pain control properties. And the other part of it is it doesn't cause respiratory depression. So in our palliative care patients right now is a great example. We're using a lot more ketamine as a continuous infusion for them, because what happens is that it has calming properties, but it also has really great pain control properties. So if you give a low dose of ketamine, which have very, very good analgesic effects and very minimal sedation effects, then you get very nice pain control. But if you need to jack that rate up to get them sedated and out, you can do that without any problems. Just give them a bolus and you jack up your rate.
And there's nothing to show that, like, say you had that patient with reactive airway disease and you used it for RSI to cause some bronchodilation. There's nothing to state that that drip would continue bronchodilation. Is that correct? I've never found anything that.
I think I haven't really pulled the status epilepticus, or I mean the status asthmaticus data. I was looking predominantly more at the CICU and SICU
Sure.
data for use, so I wouldn't know. I would assume because of the dilation effects from that perspective, you probably would have continued dilation of the vasculature in the lung area,
Okay.
but I don't know that for certain.
Yeah, I think, I mean, you know, our dilemma is, you know, if we're gonna start a drip on something, and you show up at Children's with a patient on a
You're all
ketamine drip.
confused.
Yeah, there, you know, I think if you have a primarily pain-driven problem, like a bad burn, I don't think anybody would disagree with that. But I mean, if you showed up with a ketamine drip on an asthmatic patient, you know, that may be like, where the hell did you get that?
I made it.
That's
That's
right.
Yeah.
Probably-
I made it.
You can put
I'm
on
gonna
your
get this
little-
birdhouse. I made it too.
You can put on your little cowboy
Like
hat.
showing up with a propofol drip on a pediatric patient, they're like, what the hell, you know, I mean.
Brandy said we could do it.
I made it.
It's a 1-to-1.
I'm pretty sure there's people at the university that already think I'm crazy, so that's okay. You blame it on me. I've been called crazy a couple
So
of times.
I'm just curious, you know, they use the ketamine infusions for chronic pain patients who have become opiate
Yeah.
resistant. And so I'm just, how do they think that works? The mu and the kappa, I mean, do they have any idea how that resets their opiate receptors then, or?
I don't
just
really know about the reset component of it, but I know in patients that are acute on chronic pain, because they already, so for example, I'm a chronic pain patient and I live on a chronic pain level of 6. And every day I get up and I take my 120 BID of OxyContin and I take my Q4 oxycodone, immediate release, probably 30 milligrams. And that's how I go through my day. And my opioid receptors are jacked. They are on that drug all day long. And then all of a sudden, I come in for a procedure, even the most minor procedure. I have no ability to manage my pain at that point because I live at a 6 and now I'm a 9. And I have already covered every single receptor site with that opioid, with those new opioids. And now I have to find something that's going to potentiate beyond that. And that's where the ketamine comes in, because one, it does sit on the NMDA receptors, and so there is a calming effect to it, but also because of the kappa component of it, you're going to get receptor sites that you've never hit before with your opioids. And so you potentiate it in that way, but also there is some mu activity, so if there's any additional mu receptors left, I doubt it, but then you have that ability also with the ketamine. And I think when our bodies are pretty amazing, and what I've started to realize as I read more and more about, especially about neurotransmitters and receptor sites, is that your body always tries to maintain that equilibrium of receptor sites. So as I pound my opioid mu receptors, they're going to downregulate. So I'm not going to have as many opioid mu receptors, but what I am going to have is more kappas. And so even a mild amount of activity on those kappa receptor sites are going to positively affect my assessment of what my pain is when I'm in a hospital. So I think that's probably a component of how it plays into it. But
so, and have you them on it for like 24 hours, or how long for chronic pain patients who are trying to get?
It just depends on how quickly they move out. So what we've done, so we actually have ketamine PCAs that we'll put on acute and chronic pain patients up on the floors, and then they get to determine how much they need, and over time their requirements go down. And so you start adding back their normal medication, and then they get to the point where they don't need any more of the ketamine. They've got all their normal medication on board, and they're back to sort of a normal baseline. In the ICUs, it's a little bit more challenging because your pain assessments are going to be going off of the pain assessments that you do as a nurse. So it's just going to be hit or miss in terms of how the patient's responding, and then when you start titrating it down. So there's not really a fast and hard rule in terms of ketamine. Historically, I think physicians have always wanted to get ketamine off first because that's what they're most comfortable with. But more and more the literature is saying what you should actually do, especially in patients that have been on high-dose opioids and benzos in the ICU for a long period of time, is start your ketamine, get them comfy, and then start going down on your other meds, get those completely off, and then slowly titrate down on your ketamine, and you significantly improve the withdrawal symptoms, or you negate any withdrawal symptoms. So there's that part of it as well.
So are you seeing a lot more chronic pain patients who are getting admitted by their pain specialists for this ketamine infusion thing?
Mm-hmm. Yep.
So we're doing that here?
Mm-hmm.
And then do all the pain docs do that, or they're just?
Not all of them. I think it's still pretty new, but you're definitely gonna start seeing, I think you're gonna start seeing it more. We have a frequent flyer that regularly comes in for his ketamine infusions. And then from an outpatient perspective, in some of these psychiatric areas, they're actually starting to use it a lot more too for the refractory depression patients. So, and that's every couple of months. But that's the kind of the beauty too of ketamine, is there is a reset button to it. It's just depending on the patient how long it lasts.
So it's like the new ECT.
Kind of.
Electroshock therapy.
It's probably a lot more enjoyable than ECT.
Awesome, thank you very much.
Yeah.
Yeah.
Sorry, felt like a little jumbled. Oh, I did have more, but
Yeah, keep
you
going.
know.
More like Madonna.
Yeah, it's not just a drug in vogue. So, does anybody know Carlos Basso, the pulmonologist?
Yeah.
He tried to tell me a couple of months ago that ketamine's, it's just in vogue right now. Soon it's going to be replaced by Demerol, which made me laugh. And I was like, no, it's more like Madonna. Sucker's not going away. And then in Europe, there is actually a new isomer that they're testing. It's called S-ketamine, and it's a active S-isomer. Pretty much kind of the same mechanisms, but it doesn't have the hallucinogenic properties associated with it. So they're testing it. The data is not super convincing to me either way. I don't know, we'll see as there's more and more data coming out, but there may be a component of the hallucinogenic, so the isomer that actually has more benefits than just the hallucinations. So we'll see what turns out. Thanks to Europe for doing our research for us. And then ultimately it's actually a pretty, in the grand scheme of things, safe drug. If you're looking at most of the drugs we use, I would argue that ketamine is just as safe or safer than our opioids and our benzos. So, and is definitely a potential option for therapy. And then of course I had to do things that you would hallucinate about, because why not? The top one is what I always hallucinate about. Those ones, it's Halloween.
Do you dream then of eating large quantities of chocolate? Or you dream of watching a lady eat large quantities? That's you.
Trip on that cat, man.
Yeah.
The cat. Well, this was, the night nurse, right?
I'd say before I gave a ketamine, I let
Like a
her
black
know
light in
what
there or
to
something?
expect though.
Yeah.
And then I always do power suggestion, what do you like to do? Go to your happy place.
Keep
Any
your
other-
hands out of the kid's face when they do it.
Yeah.
Hey, Johnny.
You've got horns!
I just one kid who dislocated his elbow as he was coming out, he goes, I hate wrestling, I never want to wrestle again.
Mom and Dad love that.
I feel